Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at Manic Community Health Center for hosting today's session, When to Order an Echocardiogram with Dr. Robert Master. Dr. Master is currently an adjunct clinical associate professor in the Department of Medicine at Stanford University School of Medicine, where he focuses on teaching the next generation of physicians about bedside medicine, critical thinking, and the art of diagnosis. For over 30 years, he was an interventional cardiologist in a large multi-specialty group with a practice that spanned from general cardiology to imaging. And we're just very, very lucky to have Dr. Master as one of our MAVEN Project volunteers. So Dr. Master, when you're ready, please begin.
Great, thank you. So today's topic is when to order an echocardiogram, and what we're talking about today is a transthoracic echo. I think ordering a transesophageal is beyond the scope of today and really is the purview of a cardiologist. But primary care doctors order transthoracic echoes all the time. And as with any test, the only reason to order a test is if it's going to do one of three things. One is change treatment, if it's going to change the diagnosis or provide a diagnosis, or if it'll change the prognosis. So I think ordering an echo for curiosity is not a good idea, but if it's going to do one of the above three things, then I think it makes sense. And I think there basically are three indications come under three flavors. One is symptoms that we'll talk about. Next is signs, and then last is lab and imaging. In terms of disclosure, I have nothing to disclose, and this is just the accreditation that I'll be speaking for about 50 minutes about how to order an echo, when to order an echo, how to do that appropriately, and then hope to leave time at the end for Q&A. So, why order an echocardiogram? And there basically are four symptoms of cardiovascular disease: shortness of breath, chest pain, palpitations, dizziness, and syncope, right? And I think when people, and then as we'll talk about, there are certain things that come up that suggest either fever or stroke that are also indications and come under the heading of symptoms. So let's just talk about shortness of breath first, or a change in exercise tolerance. If you hear a murmur, or if you don't, there still is a possibility of aortic or mitral valve disease. And both of those can change exercise tolerance. So one of the hallmark symptoms of aortic stenosis, for example, is a change in exercise tolerance. Pulmonary hypertension of whatever cause can cause shortness of breath. And pulmonary hypertension, we're going to during this talk, talk also a little bit about clinical cardiology. Pulmonary hypertension comes in three flavors: pre-capillary, capillary, and post-capillary. So pre-capillary pulmonary hypertension just means left to right shunts. So it's pulmonary hypertension due to problems that occur before the pulmonary arteries. Any kind of pulmonary disease can cause pulmonary hypertension or capillary. So the most common being chronic obstructive lung disease, but could also be pulmonary emboli or interstitial lung disease. And then there's post-capillary, which would be heart failure and mitral valve disease. Those are the most common things. And these days, people are very much aware that heart failure can be due to reduced ejection fraction or preserved ejection fraction. And reduced ejection fraction is typically associated with an elevated BNP and rather typical symptoms of heart failure. But heart failure with a preserved ejection fraction is much harder to diagnose. And I would say the echo is more suggestive of that diagnosis than diagnostic of it. So we'll talk a little bit about that. So what might you see on an echocardiogram in someone with heart failure with preserved ejection fraction? Well, one is an enlarged left atrium, either left atrial enlargement or an increased left atrial volume greater than 34 meters per millimeter squared. That finding, that abnormality is specific but not sensitive. So if you see it, it's very suspicious, but if you don't see it, it doesn't mean that the person doesn't have heart failure with preserved ejection fraction. So what are some of the other things you might see with heart failure with a preserved ejection fraction? You might see concentric left ventricular hypertrophy. You might see pulmonary hypertension. And you might see Doppler evidence of diastolic noncompliance, and I'll go through some of these findings in just a moment. Once again, diastolic noncompliance is specific but not sensitive, meaning that if you have it, it's very suggestive, but if you don't have it, it doesn't exclude it. And it's important to realize you can have heart failure with preserved ejection fraction without diastolic noncompliance, and you can have diastolic noncompliance without heart failure with preserved ejection fraction. So it's a tough diagnosis. So what are some of the Doppler indices? Well, one is an E greater than A, which you can see on just the routine echocardiogram. And normally the A is greater than E. So E greater than A would be one evidence. An E to E prime ratio, which is early diastolic transmitral inflow velocity over microannular tissue velocity. And once again, this is specific but not sensitive. You can see pulmonary vein flow reversal and an E over SRE, which is sort of an E velocity, which is the early transmitral influx over LV strain. So there are some indices here. I don't think the specifics are so important as the concept that there are various Doppler evidences of diastolic noncompliance that suggest but don't prove heart failure with preserved ejection fraction. What about chest pain? Well, chest pain, obviously a clinical history is very important here, but if you're not sure, there are certain things that show up on an echocardiogram that are quite helpful. One is dissection of the ascending aorta, a pericardial effusion, and realize you can have pericarditis without an effusion. So a negative echo doesn't exclude that diagnosis. Realize, early pericarditis is non-effusive, and so if you see an effusion, it's very helpful. If you don't see one, it doesn't exclude that diagnosis. Chest pain could be due to a hypertrophic cardiomyopathy. So someone who has what sounds like exertional chest pain, but the person doesn't have any coronary risk factors, and you hear a murmur, particularly with exercise or with Valsalva, or when you have the patient stand up, that suggests a hypertrophic cardiomyopathy. And chest pain after an infarct, an echo is very helpful. Now, this is something that most typically is assessed in the hospital. And the question there is, does the person have post-infarction angina? Did they have a Dressler syndrome, post-infarction pericarditis, or do they have a perforation of the left ventricle, which is typically due to dissection through that part of the heart muscle that's been infarcted into the pericardium, and you would see a pericardial effusion. But you would see other factors as well. Palpitations. So a patient could present to you with palpitations, and your index of suspicion about what's going on is increased if they have structural heart disease. So, once again, if you have structural heart disease, that puts the person in a different category, but the absence of structural heart disease certainly does not exclude arrhythmias. There are plenty of patients who have, for example, supraventricular tachycardia, who have no structural heart disease. On the other hand, if someone has palpitations and pre-syncope and has severe LV dysfunction, that makes you think of ventricular arrhythmias. If someone has atrial fibrillation with a rapid ventricular response and left ventricular dysfunction, it's a real challenge because it could be an arrhythmogenic cardiomyopathy, or it could be the other way around. So it's hard to know which is chicken and which is egg. Did the atrial fib cause LV dysfunction, or did LV function cause atrial fibrillation? But at least that diagnosis is suspected from an echocardiogram. Next is dizziness and syncope. And in a patient who has exertional dizziness and syncope, that particularly suggests the heart is the cause. So things that are associated with that are pulmonary hypertension, either primary or secondary, a hypertrophic cardiomyopathy, aortic stenosis, arrhythmogenic right ventricular dysplasia, and some structural heart disease. Once again, all those things make you think that the heart is the cause of the dizziness as opposed to other causes of those symptoms. Next is fever. And typically this is an FUO, or fever of unknown origin. And, your concern is to rule out endocarditis. If the person has a pacemaker, a cardiovascular implanted electrical device, either a pacemaker or defibrillator, the question is the pocket infected? Is the lead infected? Is there, so those are a very helpful thing. And it's often impossible to distinguish between thrombus and vegetation certainly on cardiovascular implanted devices. But once again, the transthoracic echocardiogram is the first screening procedure. And lastly, the patient has a stroke or a TIA, and let's say their carotids are clean, or they're too young to have a typical stroke. One of the possibilities is a patent foramen ovale, or PFO. And if you're concerned about this, a bubble study is recommended. So what's a bubble study? And people don't realize there are no bubbles in a bubble study. What you do is the patient, before you do the echocardiogram, is hooked up to an IV. You withdraw with a 10 cc's of saline, and you basically shake it up. So these are micro bubbles. These are not visible bubbles. And you inject, while you do an apical four-chamber view, you forcibly inject antegradally into the vein. And what you'll see is that the microbubbles act as a contrast agent. So you should see first filling of the superior vena cava, the right atrium, and then the right ventricle. And then that contrast, or those microbubbles, are cleared by the lung, and you should see no contrast in the left atrium or left ventricle in a normal patient. If you see that contrast go from the right atrium to the left atrium, you know that there's a right to left shunt. And then if you see it go from the right atrium to the right ventricle and then to the left ventricle, you know there's a right to left shunt at the ventricular level. So basically, a bubble study is not a macro bubble, it's micro bubbles. It's due to agitated saline, and it functions as a contrast agent. So what other echocardiographic findings might you see in someone who's had a stroke? Well, you might see mitral valve disease. One of the classics is silent mitral stenosis. Could be endocarditis, and the patient may not have noticed any fevers. They may just feel like they have night sweats, might be a complaint, or they might feel heat intolerance. They may have very low grade febrile symptoms, especially if they have subacute endocarditis. A mural thrombus, so someone who has had a previous apical infarction. If that's not endothelialized, thrombus can break off and embolize to the heart. Masses such as an atrial myxoma that may present as a stroke, or a dissection may present as a stroke. So these are all the symptoms that people may have that would say an echocardiogram is a good screening test. What else? Well, what if the patient has had a history of congenital heart disease or repair. And I think even with repair, you might want to get an echocardiogram to see, okay, some of these complex anomalies require more than one operation and are not, or perhaps they've had a repair, but they've had some recurrent problem. What about a hypertrophic cardiomyopathy? Well, the current recommendations are, so this is both if you're suspecting the patient has a hypertrophic cardiomyopathy or if there's a family member and you're doing screening. So what's the current recommendations? Well, for primary relatives, so someone in the immediate family, children, parents, it's recommended that they're an adult to get an echocardiogram every 5 years, but if they're under 20, to get one every 1 to 2 years. And this is because hypertrophic cardiomyopathy may not be apparent on an echocardiogram on a child at age 5, but apparent on an echocardiogram at age, say, 10. So as kids grow, the phenotype, the manifestations of a hypertrophic cardiomyopathy become evident. Now, obviously, echocardiograms are not inexpensive, and doing that every 1 or 2 years in a pediatric patient is expensive. So more commonly, if the primary person with the hypertrophic cardiomyopathy has genetic testing, you can do genetic testing on the family members as another type of screening test rather than repeated echocardiograms. The other reason to get an echocardiogram on a family member would be if there's a change in symptom status. So, if let's say a father has had hypertrophic cardiomyopathy and a child suddenly notes that, they're more short of breath, or they pass out or have an episode of sudden cardiac death, that would be a reason to get an echocardiogram. And that leads us to number 9, family history of sudden cardiac death. This could be due to hypertrophic cardiomyopathy. It could be due to an inherited cardiomyopathy. So there are many possibilities, but if there's a family history of sudden cardiac death, I think an echocardiogram is a very reasonable screening tool. Next, if the patient has pulmonary embolism and there is a suspicion of pulmonary hypertension, the best way to diagnose that is with an echocardiogram. In fact, an echocardiogram is very helpful for all the types of pulmonary hypertension that I mentioned, precapillary, capillary, and postcapillary. So it should show evidence to either show a left to right shunt. It may just show isolated pulmonary hypertension, and people have capillary hypertension. And if there's left ventricular dysfunction or mitral valve disease, that'll also show up on an echocardiogram. So very helpful test in that clinical situation in which pulmonary hypertension is suspected. Next is valvular heart disease. You hear a murmur. You're not sure if it's significant or not, or if the patient has a history of prior valve repair or replacement. Periodic assessment of the valve repair or replacement is reasonable, especially if you suspect that, let's say it's a bioprosthesis and you suspect degeneration, or there's been a repair and you hear a new murmur. That would be a reason to get an echocardiogram. Next is Marfan syndrome. And Marfan syndrome is interesting. If you think about it, there's some not such great things about Marfan's syndrome, including a dislocated lens, but really the serious life-threatening things are cardiac that have to do with either mitral valve prolapse with mitral regurgitation, or aortic root dilatation and a risk of either dissection or rupture. So if someone with Marfan syndrome doesn't have any cardiac disease, it's a tremendous relief. On the other hand, if someone with Marfan syndrome does have either a prolapse with mitral regurgitation that's significant or aortic root dilatation, then those people need to be monitored carefully. And whereas generally elective surgery is recommended for most patients without Marfan's if the aortic root is greater than 5.5 centimeters, in Marfan's if it's greater than 5 centimeters, because of the risk of dissection. So the recommendations for elective aortic root replacement are different in patients with Marfan's than people who don't have it with a lower threshold. Next is patients with suspected hypertensive cardiovascular disease. Now, if you think about it, high blood pressure is a surrogate marker. We don't really care if a patient's blood pressure is elevated per se. It's a number. What we care about is the damage that high blood pressure causes to certain target organs, the eye, the brain, the heart, and the kidney. So if you suspect that the person has hypertensive cardiovascular disease, for example, LVH on an electrocardiogram or cardiomegaly on a chest X-ray, an echocardiogram is very important to document that involvement, because what that tells you is that you need to be more aggressive in the treatment of that particular patient than if someone doesn't have any end organ damage. So right away, end organ damage puts that patient in a high-risk category. So imagine you're treating someone with high blood pressure, but they've actually developed left ventricular dysfunction. That's a whole different thing than a whole different clinical context than treating a young, healthy person who has borderline blood pressure and a normal heart. And lastly, an echocardiogram is reasonable if a patient's going to be treated with cardiotoxic drugs in their chemotherapy, both for initial evaluation as well as subsequently. So those were the historical symptoms that would make you order an echocardiogram. What about the signs? So let's say on physical examination, you hear a murmur, or you hear clicks or a gallop, or fixed splitting of the second heart sound, which is indicative of an atrial septal defect typically. Those are things that would make you order an echocardiogram. On physical exam, if you hear an increase in the pulmonic component of the second heart sound, so, normally what happens is the aortic component is louder than the pulmonic, but if you hear a crescendo in the clicks, the components of the second heart sound rather than a decrescendo, that makes you think of pulmonary hypertension. In addition, a left parasternal heave can be indicative of pulmonary hypertension. So remember, the right ventricle is anterior. The left ventricle is more posterior. So if you put your hand in the left parasternal area and you feel the heart heave with each heartbeat, that's abnormal, and is indicative of right ventricular overload and would be a reason to do an echocardiogram. Let's say you notice that the patient has cyanosis or clubbing. That would be an indication for an echocardiogram. So what's clubbing? I know this is fairly basic, but if you think about it, it's a little bit hard to define. But really, when you talk about clubbing, what you're saying is that the fingernail looks like an inverted spoon. It's basically a nail deformity in which the distal nail curves downward. And you see this in several clinical scenarios. You can see it in heart disease, lung disease, gastrointestinal disease, and other things. But the cardiac causes of clubbing are fourfold. One is any heart disease that causes chronic hypoxia or low oxygen tension. Secondly, any cyanotic heart disease. So typically anything that's a right to left shunt. Subacute bacterial endocarditis can cause clubbing, and an atrial myxoma can cause clubbing. So you can, if someone has clubbing, maybe they just have clubbing, but maybe they have some heart disease, and an echocardiogram helps with that. Tachypnea. So let's say the patient may not complain of shortness of breath because they're very sedentary, but you notice, gee, they're breathing 30 times a minute. It could be cardiac, it could be pulmonary. So you want to evaluate the heart. We talked about hypertension, and we talked about the need to do an echocardiogram if you suspect hypertensive cardiovascular disease. But it can also help you in terms of assessing whether or not someone has coarctation of the aorta. So I once saw a patient, a woman, who had 3 pregnancies. And with each pregnancy, she became hypertensive. And so she was diagnosed as having preeclampsia. And she was referred to me after her third pregnancy and delivery because she was noted to have a heart murmur. And she was rather surprised when I checked the blood pressure in her legs, which was markedly diminished compared to her arm. And she had coarctation of the aorta. And she was actually quite fortunate because she could have had a stroke during her pregnancies and delivery, which is one of the complications of coarctation in a female who gets pregnant. So the hallmark of coarctation is strong, if not elevated pulses in the upper extremities and diminished pulses in the lower extremities, often with left ventricular hypertrophy, often with diastolic dysfunction. You may see left atrial enlargement, pulmonary hypertension, and often you see aortic root dilatation, but that's because there's constriction at the coarctation. So an echocardiogram is helpful in that scenario. Lastly, a diffuse or laterally displaced PMI. And one of the trick questions I ask the medical students when I teach is, what causes a diffuse and lateral PMI? And usually the students will say an enlarged left ventricle, which is only partially true. So the PMI is given a purposely ambiguous name because it could be either the right or the left ventricle or both. So remember, the interventricular septum is at an angle of about 30 to 60 degrees. And so the PMI normally is the left ventricle, but if the right ventricle is enlarged, it's the right ventricle. If the left ventricle is enlarged, it's the left ventricle, and sometimes both ventricles are enlarged. So when on physical exam, you notice that the PMI is diffuse and laterally displaced, meaning to the left of the midclavicular line and bigger than a quarter, you may or may not see something on the chest X-ray, but an echocardiogram will help you define why the PMI is enlarged or laterally displaced. What other things? Well, what if the patient has edema, ascites, and hepatomegaly? And of course, the first reaction is, well, this is cirrhosis. And especially in a patient with, say, alcohol abuse, you think, oh, this is alcoholic cirrhosis, but it could be cardiac cirrhosis. So any cause of right heart failure, and which includes pulmonary hypertension, or pericardial constriction can cause ascites, edema, and hepatomegaly. And the liver in this case is not the primary problem, it's the secondary cause to the heart problem. And so you could miss pericardial constriction if you assume, and therefore a curable cause for the person, ascites, edema, and hepatomegaly, if you don't do an echocardiogram. So I think, even in a patient with alcohol abuse, it's interesting. Some people with alcohol abuse have primarily liver toxicity, but some people have primarily cardiac toxicity. And I tend to think it's more of a genetic predisposition, but it could be that the person's symptoms of right heart failure, which include these three findings, are due to the heart and not primarily liver. Next, if you notice on physical exam that the Jugger Venus pressure is elevated, and let's just talk for a second how you measure that. So the sternocleidomastoid joint is about 5 centimeters above the mid-right atrium, and almost no matter what position the patient is in, supine, sitting, or at an angle. So you measure the JVP by how much elevated it is above the sternocleidomastoid point plus 5 centimeters, right? So anything over 9 centimeters of water is elevated. So if you notice it's elevated, that could be due to right heart failure or pulmonary hypertension, could be constriction, could be tamponade. An echocardiogram will help you with that differential. So one of the questions, once again, that I teach, and I'll just share this, is about, well, how do you distinguish when you see a pulsation in the neck, whether it's arterial or venous? So if you can feel it, if you feel the pulsation, that usually means it's arterial, therefore it's likely to be the carotid. On the other hand, if you see both two pulsations for every heartbeat, that suggests it's venous because what you're seeing is an A and a V wave. If you see as the person breathes in the venous that pulsation decreases, that suggests it's venous because as you breathe in, you create negative intrathoracic pressure and you decrease jugular venous pressure unless the person has what's called a Kussmaul sign, which is paradoxical increase. And you can see that in constriction. Lastly, if you can, with compression, eliminate the pulsation, that with gentle pressure, that suggests it's venous rather than arterial. Arterial would require much greater pressure to get rid of. So you can, with just some simple bedside maneuvers, figure out whether a pulsation is arterial or venous. Next is if the person has a paradoxical pulse or a rub. So what's a paradoxical pulse? Well, it's if as the patient breathes in, there's greater than a 10 millimeter change in when you hear the Krakow sounds. So for example, you may hear just an expiration Krakow sound, blip, 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 and then blip, 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 blip. So it's when you hear the first Krakow sound to where you hear it consistently through the respiratory cycle, that's the paradox. And anything over 10 is abnormal. And that's seen typically in tamponade, but can occasionally be seen in constriction. If you hear something that sounds like a rub, once again, you want to know, well, is it effusive disease or is it just pericarditis without a rub? So an echocardiogram is helpful. We talked about an arrhythmia in terms of determining whether or not there is associated structural heart disease with, for example, atrial fib or ventricular tachycardia. We talked about determining whether or not the heart might be the source of an embolism in the setting of a stroke. What about if there are peripheral stigmata of endocarditis, and what are those? Because this is a bit of a review. So there are four typical peripheral stigmata of endocarditis. One are rough spots. So you look in the eye, you do a fundoscopic exam, and you see these white centered retinal hemorrhages. And that's one manifestation of endocarditis. A second is splinter hemorrhages. So you look at the nail beds and you see these linear red streaks. And it could be just due to trauma, but if you're worried about endocarditis because of other signs and symptoms, a echocardiogram is the way to go. A third peripheral stigmata are what are called Osler nodes, where you have these erythematous lesions of the hand and feet. And lastly, there are Janeway lesions. And Janeway lesions are seen on the palms and the soles of the hands and the feet. They're non-immunologic. So the Osler nodes are thought to be due to deposited immune complexes, whereas the Janeway lesions are not. And like I say, they're seen on the palms and soles. So those are the things that make you think, oh, I should get an echocardiogram because I should be thinking about endocarditis. Next, and this is something that's once again more in the inpatient setting, is hypotension. And so if a patient comes in with a blood pressure, walks into your clinic and has a blood pressure of 80, I think the next thing is to call 911 and have them taken to the emergency room. But I'll just mention that an echocardiogram can be tremendously helpful in a patient who's hypotensive. So what are the possible causes? Well, it could be anaphylaxis. The person could be hypotensive because they took something that they're allergic to. It could be cardiac. It could be they have significant pump dysfunction from an MI or LV dysfunction, or it could be that they had a massive pulmonary embolus. It could be due to sepsis. Could be due to hypovolemia, either blood loss or, in this case, due to the fact that the ambient temperatures in the world seem to be elevating. It could be to endocrine dysfunction, so low thyroid, and low cortisols. Addison's disease can cause hypotension. And these days, Addison's typically is iatrogenic, so I often would take a history, and you want to find out, has the patient recently been on high-dose steroids, for example, for their asthma, and they were too quickly tapered, they're stressed, and now their adrenals have been suppressed by exogenous steroids, and they're hypotensive for that reason. Neurogenic causes. So neurogenic causes might be, for example, neurocardiogenic syncope. Someone comes in after the sight of blood or having their own blood drawn, or could be due to the fact that they have orthostatic dysfunction for a variety of reasons, including autonomic dysfunction. Lastly, there are certain drugs that cause hypotension. Obviously, too much antihypertensive medication, diuretics, etc. So there are many causes of hypotension, and those are the 7 causes. I remember as an intern trying to memorize these because inevitably people were hypotensive in the middle of the night. The nurse would call you, Mr. Mrs. So-and-so has a low blood pressure, and I'm going through these 7 possible causes based on what I know about the patient. So what are some of the lab things that make you think that an echocardiogram would be part of the workup? Well, polycythemia. Polycythemia may be primary polycythemia vera, or it could be secondary to chronic hypoxia. It could be, in this day of doping, it could be due to exogenous EPO. It could be due to, what if the patient is septic? Now, there's certain organisms that suggest endocarditis. For example, a strep viridans makes you wonder about the heart. Staph is disconcerting because at approximately 25% of patients with staph sepsis also have staph endocarditis. This can happen particularly if they have an indwelling line. And certainly if the person has a yeast, if they have a candida that grows out in the blood, you want to think about the heart. And typically the only way to cure that is with, unfortunately, extirpating the valve. Or let's say you do a blood test and the person's short of breath and their BNP is elevated. You want to get an echocardiogram to see, well, why is the BNP elevated? Because that's typically elevated when breathing is due to heart failure. So those things will suggest needing an echocardiogram. What about other imaging? Well, an abnormal chest X-ray or CT that shows cardiomegaly, a big heart, is it the right ventricle, the left ventricle, or both, or is it a pericardial effusion? Increased arterial or venous vascularity, so is it a left to right shunt, or is it due to passive congestion due to an elevated wedge pressure? Pleural effusions, is it a transudate or an exudate? You know, is it due to the heart failure, or is it due to some process that's intrinsic to the pleural space? If you see an enlarged aorta, you want to get an echocardiogram, or if the pulmonary artery looks unusually prominent. So those are all things that are tip-offs that you need more information. If a patient on CT or MRI has evidence of a stroke and you don't have an obvious source, an echocardiogram looking for an embolic source. Let's say you get an EKG on the patient and the EKG shows LVH or RVH, but you don't have a very obvious cause. Or let's say the person has high blood pressure and LVH. You want to get an echocardiogram to see, does the person have hypertensive cardiovascular disease? With RVH, you want to see that what's the person's pulmonary artery pressures? Why did they have RVH? Someone on an EKG that suggests a myocardial infarction. You know, sometimes the patterns are very diagnostic, but a lot of EKGs are suggestive and not diagnostic. And, you know, if there's a previous infarction, there should be a segmental wall motion abnormality. So an MI should clarify a possibly abnormal EKG. Arrhythmogenic right ventricular dysplasia may be one thing that's picked up on an EKG. We talked about arrhythmias, also a bundle branch block. Does the person have just a right or left bundle branch block, or do they have associated structural heart disease? And once again, with the WPW, same idea. Lastly, in a patient who has a diagnosis of pulmonary embolus and you don't have an obvious source, or the question is, does the person have pulmonary hypertension? So, most pulmonary emboli come from the legs or the pelvis. But what if the person has, doesn't have any evidence of thrombi in the legs or in the pelvis? Maybe they're throwing emboli from an atrial myxoma. So those are all possibilities. So we talked about when to get an echocardiogram in a patient with hypertensive disease, and it's mainly indicated if you suspect hypertensive cardiovascular disease and LVH, because that suggests you need to be more aggressive with treatment. It could be LVH or it could be LV dysfunction. An echocardiogram is not, so if you look, I have here for patients as part of a routine evaluation of anyone with high blood pressure without suspected hypertensive cardiovascular disease. So a young patient with a normal EKG, or here's reevaluation of a patient with known hypertensive heart disease without a change. So someone who you've already documented has hypertensive cardiovascular disease. The I stands for indeterminate or inconclusive. So it's less than clear that it's recommended to do an echocardiogram under those circumstances. I personally would not necessarily recommend it. Let's say you've treated someone with high blood pressure for years, they had LVH, and their LVH when the EKG goes away. Your curiosity might be, oh, let me get an echocardiogram. But that's not, like I say, curiosity is not necessarily an indication for an echocardiogram. Lastly, aortic disease, and we talked a little bit about, what are the indications for elective replacement, and what if we just see the aorta is somewhat big, but it doesn't meet indications for elective aortic replacement. So a normal ascending aorta is less than 4 centimeters. So if it's less than 4.5 centimeters, check it again in 3 to 5 years. If it's 4.5 to 5 centimeters, they recommend checking it every 2 years. If it's over 5 centimeters, it's recommended to check it every year. And if it's over 5.5 centimeters, it's recommended that it electively be replaced and the patient be referred to a cardiac surgeon. And as I mentioned, if the patient has Marfan syndrome, and if it's over 5 centimeters, they recommend elective aortic replacement. So those are really, I think, the highlights of things. I think that, an echocardiogram is a very safe test. It's not known to have any risks. It is, however, an expensive test. I don't know how much it costs these days. Usually the cost depends on the clinical setting, whether it's a private doctor's office or a hospital or a doctor's practice that's been taken over by a hospital. So, I think it's become a tool almost like an EKG, but it should be reserved for situations in which, as I mentioned in the very beginning, you're considering that the results of the echocardiogram will change either the prognosis, the diagnosis, or it'll change your treatment. It shouldn't be done for curiosity. So at this point, I'll open things to Q&A and see if people have questions about order an echocardiogram or anything related cardiologically.
Thanks, Dr. Master. We have 2 questions right now, but please feel free to put them in the Q&A box, chat box, use the raise hand feature. First question. Do you get a baseline EKG upon diagnosis of hypertension on all patients? And an echo if you see signs of LVH or CAD on the EKG?
Yeah, so that's a great question. And I think that I would get an EKG on every single new hypertensive patient for 2 reasons. One is, do they have hypertensive cardiovascular disease? Is there anything that suggests that the hypertension isn't just a number? And I mentioned high blood pressure. The number high blood pressure is a surrogate marker for disease. The number is really a window into end organ damage that's ultimately created by that number, but the high blood pressure is just a number. So I think one reason to do it is their LVH. And I also think that a single EKG as a screening test for a lot of patients makes some sense. And it may be a window to other evidence of heart disease. So I would get an EKG on every hypertensive patient and only an echocardiogram on those people who had some significant abnormality.
Thank you. Next question. When would we order a stress echo?
Okay, so a stress echo is different. A stress echo is to pick up ischemia. And so what you see so one of the first things that happens with ischemia is that there's a decrease in myocardial contractility in that segment that's subserved by a narrowed coronary artery that's hemodynamically significant. So you do a baseline echocardiogram, and then you have the patient exercise, and as soon as they're finished, you have them lay down and repeat the echocardiogram. And usually you should see an increase in contractility of all wall segments immediately after exercise. So if you see any segment that becomes hypofunctional or akinetic or dyskinetic, that's definitely abnormal. So when would you order that? Number one, it's another layer of testing in a patient who has an abnormal stress test. Now, in a stress test in a patient who has typical angina, a stress echo will give you prognostic information about how much of the heart muscle is not receiving an adequate blood supply. So let's do, you get a result as someone has a positive stress test. Okay, so you're going to treat them with medication, but the question is, should they undergo revascularization? And you want to get an idea of, is their angina just due to a small part of the heart muscle getting an inadequate blood supply, or a large amount of the heart muscle getting an inadequate blood supply? So an echocardiogram, I think, in the situation someone has typical angina, gives you important prognostic information, so that if you saw a large part of the left ventricle that was hypokinetic, akinetic, or dyskinetic, you would refer that person to a cardiologist for consideration of revascularization. It might mean that they need a stent, or they might need bypass surgery. What about the person with atypical chest pain? That person, I think, let me go to an easy one, which is with atypical chest pain or non-cardiac chest pain. Person with non-cardiac chest pain probably shouldn't have had the stress test in the first place. If someone has either no pain or non-cardiac chest pain, the likelihood that abnormal stress test is a true positive is about 20 to 25%. So someone with non-cardiac pain or non-cardiac pain, the chances are 4 out of 5 or 3 out of 4 that's a false positive test. So you can then either go to a stress echo or nuclear test. And I think, for whether you order a nuclear or a stress echo depends on a number of factors. And that includes, the person's age and their sex. So for example, a young woman, so the amount of radiation for a nuclear stress test is about equivalent to 1,000 chest x-rays. Well, that's not much of a problem for a 70-year-old male, but I don't think it's a great idea for a 30-year-old woman. So I would preferentially use a stress echo, particularly if there's the expertise in the community to do a stress echo. If there's not the expertise, that's a different story. But it's a safer test, I think, long-term in a younger, especially female patient, that you're concerned about coronary artery disease. I'm less concerned in an elderly patient, particularly male. The other thing that I think influences your decision about ordering a stress test is how obese the patient is if they're obese. So if someone is severely obese, you're not going to have a good acoustic window to get a great stress echo test. And so if you had someone who's morbidly obese, positive stress test, a stress echo is going to be a suboptimal test in most cases, and I would shy away from that. On the other hand, if the person is thin or only mildly obese, then a stress echo is a reasonable option. So to sort of summarize, a stress echo is a good test to use if a stress test is abnormal for whatever reason. I would tend to use it, whether you use it or not depends on local expertise. So if there's someone who in your community who can do a stress echo and that's an option for you, I would particularly send a young female and thin patient for that. Whereas an older obese male patient would tend to go, my next choice would be nuclear because I personally feel a little more comfortable. It's less subjective. So it's shades of gray rather than black and white, but hopefully I answered your question. If I didn't, please let me know.
Thank you, Dr. Metzger. Next question. Are there circumstances which would make reading an echo more difficult and more prone to false negative or positive results?
Sure. So I mentioned one, which was morbid obesity. Your acoustic windows are often less than ideal if the patient is severely overweight. That would be probably the biggest one. There's some people don't have good acoustic windows, and you don't know that until you do the echocardiogram. In some patients, for example, the heart, instead of being on the left side of the chest, person might have dextrocardia, for example, or they might have some collapse of the right lung where the heart is shifted, the mediastinum and the heart is shifted over to the right, and you get less than ideal. But those things are fairly uncommon. Dextrocardia, really, all those things are really quite uncommon. So other than obesity, I think an echocardiogram is a great screening test for the things that we talked about earlier in this webinar. And there are very few things in which there would be a false negative or a false positive, per se. Any other questions I can answer?
Let's see. Okay. In morbid obesity, what can replace an echo or what else can we order?
Well, just because a patient is morbidly obese doesn't a priori mean they don't have an acoustic window. Occasionally, based on their fat distribution, so their fat may be more in their abdomen and their buttocks and their legs. So you may have a good acoustic window, but let's say you do it and it looks like a snowstorm and you really can't get a good image. Then depending on the necessity of the echocardiogram, this is where a transesophageal echo comes in place, because basically, if you think about it, the esophagus is right behind the left atrium. And it's one of the reasons when they do a cardiac ablation for atrial fib, where they're using energy around the pulmonary veins adjacent to the mitral valve, they have a thermistor, a temperature probe in the esophagus, because one of the terrible complications of that procedure is a fistula between the left atrium and the esophagus. So there's literally millimeters of tissue between the left atrium and the esophagus normally. So usually a fistula between the left atrium and the esophagus results in bleeding from the left atrium into the esophagus and exsanguination and death within seconds. It's a pretty instantaneous event. But the flip side of that is it's a great acoustic window that doesn't really have anything to do with how the size of the patient. So if you do a transesophageal echo, the probe is really millimeters from the left atrium. So it really gives you some great visualization of the left atrium, the posterior structures of the heart and the apex of the heart. Obviously, it's an invasive test. So, this is not your usual screening test. You don't order a TEE before you try a transthoracic, because there are certain risks of putting a probe into the esophagus, including perforation. So in a patient in whom you would like to get the information of a transthoracic echo, but they're morbidly obese, I would still try first with a transthoracic echo. If you still need the information, then your options are, number one, a TEE, and then second would be something like an MRI or a CT, depending on what question you're asking and what you're concerned about, as these are other ways of getting that same information depending on what the question is that you're asking. It depends on what you're looking for. If the issue is left ventricular function, then an MRI gated image is very good. If you're looking for example, vegetations on an implanted device, a TEE is better. If you're looking for dissection, a TEE is better. So that decision, I think, really should be left in the hands of the cardiologist that you're referring the patient to. But I would start with a regular transthoracic, even in a morbidly obese patient, and then let the cardiologist to whom you've referred the patient to make that decision based on their knowledge of what the question is and what's going on with imaging modalities in that particular community. Because in some communities, for example, an MRI is not available, or a CT may not be, or a TE may not be available. But those are the options.
Great.
Any other questions?
We have one more. I just want to, before we get into this, we only have 1 minute left. If we go a little bit over, we'll continue recording. Just a reminder with your CME survey, correct date, July 2nd, correct speaker, Dr. Robert Master, and you should get it as soon as you complete the survey. Last question. Oh, big words. Can microemolia in the lungs cause right heart strain like larger PEs? And do you see this with COVID?
Okay. So the question is whether or not submassive pulmonary emboli can cause right heart failure, and can you see this with COVID? The answer is yes and yes. So sometimes you have a massive clot that breaks up and disperses into the various pulmonary arteries. One of the complications of COVID is thromboemboli. So if you have a big clot sitting in the main pulmonary artery, that's amenable to thromboembolectomy, surgically or otherwise. But I've unfortunately have seen a fair number of patients with thromboembolic pulmonary hypertension in which that's not an option. The emboli have gone to the subsegmental pulmonary arteries, have endothelialized, have not been dissolved by the body's own lytic system, have called pulmonary hypertension. That could be a sequelae of COVID. So that definitely is a possibility.
Okay, now one more question. I promise, last one.
That's okay.
If a patient has known aortic stenosis on echo, done for dyspnea eval without
Dyspnea, yeah.
You know, big words in me. Without hypertension, as likely due to age, does an echo needed to be repeated at a certain interval?
Okay. So what happens, the question has to do with aortic valve disease in elderly patients. And so one non-hemodynamic form of aortic valve disease is what's called aortic sclerosis, where you can see thickening calcification of the aortic valve, but without a gradient. And that can, over time, become aortic stenosis. and mild aortic stenosis can progress to moderate and severe. And even in an elderly patient in this day and age, because we have TAVRs where you can replace the aortic valve without cracking someone's chest, they're doing TAVRs in patients who are 80 and 90 years, and I guess sometimes even older. So how often should it be repeated depends on what you found with the first echocardiogram. If you found aortic sclerosis, I think you're pretty safe not to repeat the echocardiogram for 3 to 5 years. If the person has a gradient across the valve, I would repeat that echocardiogram again in 2 years and every 2 years thereafter. And if they develop critical aortic stenosis, then they need to be referred to a cardiologist. So initially, their breathing may or may not have been related to the aortic valve disease. They could be, for example, they could have COPD and a non-hemodynamically significant aortic valve problem. But, you can have more than one cause of shortness of breath, unfortunately. And certainly, if you develop critical aortic valve disease, that will make anyone's breathing problem worse. So it does require some follow-up, depending on the circumstances, and the frequency depends on whether or not there was whether there was a gradient observed with the initial echocardiogram.
Thanks, Dr. Master. I don't see any more questions, so I'm going to assume that we are done. But thank you for presenting today, and thank you all for joining us and being really interactive. This was a very fun session to watch. So thank you, and have a happy 4th of July.
Yes. Thank you so much for your attention. I really appreciate it. Thank you, Chris. Take care.